Sure. Maybe just to start, let's say hello, and then my name is George Kovalevsky, and this is Dr. Emelia Bachman,
Hello, nice to see you all.
and we're very excited to be here and speaking with you and answer your questions. For me, this is very exciting because one of the most important aspects of what I do is educating patients, educating people who are looking for help. And so I strongly believe that education and information are the most powerful tools that I can offer and provide so that everyone can make informed decisions for themselves about the best next steps going forward.
I agree. I think that's also, I think that's one of my favorite parts of our job is, really talking with you and learning about what's happening and getting to know you and then making sure we're making the best medical decision for you and also the best decision for you personally, for your family. We really just find it such a joy to take care of you. And, it can be really hard and some journeys are easy and some journeys are longer, but we're here for you and that's really important. Both Dr. Kovalevsky and I are really excited to join Dr. Russell's practice and our whole staff at the Delaware Institute for Reproductive Medicine, or DIRM as we call it. Everyone has been really amazing, and we're just so fortunate to join a practice that has been around for so long and really continue to grow and develop with it. And we really loved everyone, all of our patients we've seen, and all of the people we work with. We're just so happy. So we're excited to get to know you all more tonight.
Thank you for all the comments and the welcomes in the chat. Much appreciated. And we are welcoming any questions that anyone has for us at this point. Maybe just to talk a little bit about ourselves as the information is coming up.
Mm-hmm.
I finished my fellowship at Penn 20 years ago and have been doing infertility practice for 20 years. I was in Delaware for 13 years, went to Boston for 4 years, and now back in Delaware. So definitely have a lot of experience and have learned a lot over the years about how to help people, and I learned that there's not one right way. And I think the first thing I started out is information and education, and then that way we can always pick the best path for any one individual.
I also was a Penn Fellow, but I finished 9 years ago and have been in practice as well as I've practiced in both Delaware and Pennsylvania, and I'm happy to be back in Delaware. So we're really excited to be here for all of you. Do you want to do this?
Yeah, so we have a question.
Yeah.
So it's, someone's asking, can you reflect on the use of Lupron after transfer to assist in implantation? And do you understand the science and if it supports the expense? So this is somewhat of a complicated question because the Lupron we use, if at all, generally before the transfer, not after the transfer. So Lupron can be used to allow us to control a cycle so that we can provide the best timing for the window of implantation, so we know when to put in the embryo, and the Lupron can be part of that regimen. So it's one of the many protocols that are available is to use Lupron in that type of protocol. Now, it's not necessarily an important key part of a protocol. There are many other protocols that we can utilize that are equally successful. And we always try to choose the best protocols given the situation. So these days, Lupron is something that I actually do not use frequently for most of the frozen embryo transfer protocols because it is at an expense, as the questioner stated, and also adds time and effort to the treatment. So usually it's not needed, but for some patients it is.
Also, there are some data on the use of Lupron in some patients, not all, with either endometriosis, failed implantation for several months beforehand, as well as a medication called letrozole. So on a individual basis, if that's the right thing, sometimes we do use that as well.
Next question asks about weight and fertility and IVF specifically. So yes, we know that weight is a factor for health and for reproduction in many different aspects, not just high weight, but also low weight. So women who are too thin can also have problems with reproductive functioning and healthy pregnancy. So weight certainly is a factor, and we always strive for optimal health and nutrition, and weight is part of that prior to attempting pregnancy.
I think I can also add that we are happy to see you at any weight. We believe that everyone should be taken care of. We do think there are some things we have to take into consideration as far as like safety, going to sleep in an office setting, and being able to access the ovaries. We are willing to work with you and see if we can make sure that the procedure is safe for you. We want everyone to know their risks in pregnancy, but we do believe everyone deserves a baby. So we're really happy to help you in any way. We have some also nice, really good resources with a nutritionist, and we're working with a company called Forum Health that Dr. Kovalevsky has had a lot of success with in the Boston area, and they're national in helping people with that. But again, we want to get you your healthiest, but we want you to eat healthy too. We don't want you on a crash diet. We want you to eat good food and learn. And they're also going into this like for like egg quality and sperm quality, like really important things like, you know, having a good diet and trying to, you know, do as much as possible to have a healthy lifestyle. But also remember, like, nothing's your fault, right? So, you know, lots of people get pregnant at different weights and with different medical conditions. Again, we just want to keep it safest for you and for your baby. So we're really happy to work with you and make you, you know, get the best plan for you personally. Okay.
Question about cycles that get canceled due to low response, and should anything be done differently? Poor response is one of the hardest things to deal with in the fertility setting. Different protocols can try to optimize the response, and so there's definitely things that we try to improve the response. Sometimes we use a higher dose protocol, sometimes we use a low dose protocol, sometimes we add supplement medications that can maybe improve the response. So we do try different things and different regimens, and sometimes in certain individuals they can be effective. But it is definitely very frustrating because in some cases there's not much that we can do to improve the response, and then the goal is simply to try to increase the odds of finding one or two good eggs to still give the best chance of success possible.
Yeah, I totally agree with that. And I think that it's really important to, you know, it is important to take a step back and say, okay, what did we do here? What can we do differently? You know, how can we improve nutrition? You know, external factors. Again, remember, you can't control everything. You know, some things are out of your control, but we can do everything we can. There are some supplements, while there's some that are not, you know, definitively proven. There's some things, as long as they're safe, we say, hey, maybe we try some of these things and try to, again, optimize health and nutrition, but also maybe change the protocol. Sometimes it might not be a matter. You know, I've had some patients who, and a lot of my patients will probably say, oh, she says this to me all the time. But every month we have a different group of eggs and a different cohort, and we may respond differently too. And so we always want to look at your individual situation. What's happened before? How is the cycle? How is the follicular response? How is the maturity and the fertilization? And see what we can do to optimize things for you.
And there's also a lot, as you say, luck of the month. So there are some months where someone will have a very good response, and some months not so good response. So there's also the element of randomness involved.
Yeah, but I think, you know, we are happy always to, you know, to look things through and give you our opinion and help you out and just try to do the best we can in the next cycle. I would say don't give up though, okay? Because with 2 cycles, I think it's really worth trying another one, okay?
Question about fresh versus frozen embryo transfers.
That's a good one. Yeah.
What are your thoughts about that?
Oh, excellent. So I think we don't have definitive data to say you should definitely do one or definitely the other. I feel like in the years people have been saying kind of frozen is better than fresh in a way. I think some of those reasons are, you see with the frozen transfers, some people are doing genetic testing. They're doing PGT, preimplantation genetic testing of their embryos. Also, in many of these program cycles, we're not in this hyper-stimulated, high estrogen environment with big ovaries. So now we're kind of back to normal, back to that baseline in a, quote, more natural environment. Although there were some studies that looked at some, you know, increased preeclampsia in the frozen too. So we do know that all IVF cycles have a little increased risk of preeclampsia and preterm birth compared to cycles that have not, people who have not undergone fertility treatment. So again, I usually look at the individual decision for the patient too. I think that, if you're doing genetic testing, we're doing a frozen transfer. I think for some patients who really had high estrogen levels, it's best to do the frozen to avoid the hyperstimulation of the ovaries. But some people who may have, like a few eggs and the lining looks good and the estrogen levels aren't so high, they may want, and they don't want to do genetic testing, they may benefit from a fresh transfer as time-wise. What do you think?
Absolutely. If an IVF cycle goes well within standard bounds, and the lining looks good, and the hormones look good, and a patient wants to move forward as quickly as possible, then the fresh transfer will be just fine. It will give a great chance of success with the least effort and time involved. But oftentimes there is something that doesn't look perfect in the fresh cycle, and then it's usually best to wait to do the frozen, because frozen will give us usually at least as good, if not better, pregnancy rates in those situations.
Agreed. I agree. So this is a really good question from Tammy. As a 40-year-old who lost a tube to an ectopic and haven't conceived, would you jump right to IVF? I would say obviously we always want to explore all your options, but I think at 40 with one tube, I think your chances are going to be better with IVF. There was a great study out of Boston IVF that looked at women between the ages of 38 to 42, and we did see in this age group IVF offers the best chance for success. That does not mean that someone else who may not want to go right to that can't try an IUI, but if you're asking us what's the best medical chance of that, yes, IVF would be that. What do you think?
I agree entirely, because also if you lost the tube due to an ectopic pregnancy, the question is how good even is the other tube? Why did the ectopic pregnancy occur in the first place? Did something hurt the tube? Are the tubes the problem? And then the other tube may not be completely normal either, putting the individual at lower chance of pregnancy and high risk of another ectopic pregnancy. So both in terms of chance of pregnancy, age, risk of complications, another ectopic, etc., I think all around IVF gives the best chance of success safely in the shortest period of time.
Does DIRM do anything with surrogacy? Yes. So we call that gestational carriers. We do work with many different agencies who offer gestational carriers. Some of our patients have someone they know. They may have a friend or a family member who is willing to be a gestational carrier. There are also agencies where people apply to be gestational carriers. We do have strict, recommendations on what we would accept, basically because we want you to have the best chance possible to have your baby, and we also want the gestational carrier to be safe too. So someone who's finished their childbearing, who's not too young, not too old, we can go over the details, in person sometime, who's a non-smoker, who's not had pregnancy complications, who's healthy, and then we would do our own medical evaluation. You do have a legal agreement. You do have to see a third-party psychologist who specializes in reproduction just to talk about the ethics and how you feel about it. So there is a process we have, but we do work with them. And Charlotte in our office helps us with that. She's amazing. And you can either, again, have a surrogate or someone that is from an agency. And we have a list of agencies that we feel that, are good, and many of our patients have pursued that. So we're happy to see you for that.
Great. Next question is about what causes embryos not to grow. And so I guess a way to think about it is there, in my mind, three factors that will determine whether the embryo makes it or not. Right? So embryo number one is the quality of the egg. Number two is the quality of the sperm. Number three is the environment, the lab in which the embryo is being grown. So assuming that the laboratory is a good one, and that's, I think, one of the reasons I'm very excited about working at DIRM is that the embryology part of it is quite superb, and I was really impressed with the statistics when I came here and learned about all the aspects of what's done there. If that factor being out of the picture, then it's more of a detective work trying to look at the clues and try to ascertain, is it more because of the quality of the eggs, quality of the sperm, or both? And there's often clues that we can that we can pick up on in the history or previous fertility attempts that can help us answer those questions.
I agree with that. I don't have much more to add, but I totally agree with that. So this is a good question. What fertility lab testing and hormone testing can a GYN or PCP order if fertility specialists are not covered under insurance? And then there's definitely some questions about vitamin supplements. So first of all, many of the blood tests anyone could potentially get, right? Because I mean, even if it's not necessarily infertility, many people have irregular periods. This is a medical problem. We do think infertility is a medical problem too. We do not agree with insurance companies thinking of it differently, but this is what we're dealing with right now. So when you're asking that question, some insurances are not covering this and we don't agree with it. But again, irregular periods, things like your egg reserve can still be checked when you have that, thyroid, prolactin, male hormones like testosterone, DHEAS. These are all things that a GYN or your primary care doctor can easily order for you. Even though they're not fertility tests, we also like to get all the preconception lab tests for pre-pregnancy, like all the tests your doctor would get if you just showed up pregnant. And those are all screening tests, like are you immune to the chicken pox, and are you immune to the measles, and do you need a booster before you get pregnant? The normal, like a blood count, are you anemic, like some of like vitamin D levels too, just in case, to make sure that's okay, and some other tests. So all of these things can be easily covered at the blood work. Also, a general pelvic ultrasound can probably be, easily ordered, if someone has irregular periods, painful periods. Most of us have some sort of issue, right, with some bleeding or pain in the period. So an ultrasound and blood work can easily be ordered by both of them. I think the one test I found difficulty with is the tube test, where you don't have another reason for it, sadly. But if you have very painful periods and you have a lot of pelvic pain, it could be reasonable because of the pain to look for endometriosis. Endometriosis is when the glands of the uterus, those cells, can implant outside of the uterus, and they can cause very painful periods and pain with intercourse and pain with urination or bowel movements. And so you could have a laparoscopy, which is a camera in the abdomen, to take a look for that. So these are medical things that your GYN can potentially do. And then while you're there, you can look at the tubes and things. So I think that we can do a lot with that. But again, we really hope and we push for having all of this covered for everyone, all over the country, because these are real medical issues that our patients face.
I would say that the tests probably are usually covered by most insurances. It's the treatment where we really get into issues with coverage for fertility.
Yeah.
And then certainly any physician can order the test, but many physicians may not be comfortable ordering because they are not comfortable interpreting the results of some of the tests, the hormonal ones in particular. So doing the preconception testing, definitely the general doctor, medical or gynecologist can definitely be happy ordering those tests. It's the hormone ones that take some extra expertise to fully understand and interpret based on how they relate to the entire situation.
Yeah, I think that's good. As far as the supplement question, we always recommend everyone take a prenatal vitamin before you're getting pregnant, right? The folic acid, we know for sure, it helps to prevent spina bifida and anencephaly. What are those? Those are things that prevent closure of the neural tube, so they can affect spine and the brain, forming in babies. So we like you to be on that at least 3 months before you start trying. Of course, a healthy diet is really important too. There's something called DHA. Those are the omega-3 fatty acids, and studies have shown those are really good for brain and eye development of baby. And also just for general health and your bone health and everything, I always like your vitamin D to be supplemented too. As far as other supplements, right, we don't have these double-blinded, randomized, placebo-controlled trials to prove to us that you need to take those. But there are some data and some small studies, and sometimes what we do is just weigh those risks and benefits and say, hey, for this patient who may have low egg reserve or older age who really wants to use her own eggs, maybe the benefits could potentially outweigh the risks. So things like coenzyme Q10 or CoQ10, there are some studies on both egg and sperm quality for that. Again, I think it's an antioxidant. It's used in all of our cell machinery. I think the downside is pretty low, but I can't tell you, this is going to definitely give you, this is going to improve live birth. But I do know some small studies that potentially improve some IVF success. So sometimes things like that could potentially be helpful. We do think, again, like antioxidants are great for eggs and sperm. So like lots of fruits and vegetables, and, improving, I think we can take vitamin C. Some people take vitamin E. Again, we don't know for sure. Also, sometimes you can feel like you're taking a pharmacy, right? Which can be really hard. But there are some patients who say, hey, I just want to do all these things and this is making me feel better. And I say that's okay. So we work on that together, making sure it's safe for you. There's no interactions with other drugs you're taking, and just come up with the best plan for you. Okay, but again, nothing totally quick. I don't know if you have other things that you would recommend too.
No, I completely agree. Unfortunately, we don't have any magic pills that will improve egg quality or sperm quality. There are things that maybe can be beneficial. So for the egg side of things, probably the hottest thing right now still in the country is the coenzyme Q10,
Right.
the CoQ10. So the evidence is very limited, mostly animal data, but it does possibly have some benefit for egg quality and doesn't seem to have much on the negative side. So if we use any supplements for that, that would be probably the one.
Yeah. And also, I think both of us are the same way. A lot of my patients come to me to say, hey, I heard about this from someone else. I heard, we're always willing to talk to you about it and make sure, like, hey, is this safe? Is it okay? And again, are there any interactions with the drugs you use? And then, just kind of come up with the best plan for you. I do love, we have really good advice here from our viewers. Brittany, quality eggs over quantity. It's very true.
Absolutely.
Very
that's
true.
kind of my statement after every retrieval.
Very good. We're going to hire you.
So, do we recommend a mock cycle after a retrieval? So that really varies depending on the situation. So for many, it may not be necessary. For some, it could be important. So, and it also depends what you mean by a mock cycle. That can take on very different meanings depending on the practice. And so, in some circumstances, we talk about going straight to a fresh transfer, and there's no need to do any mock cycle at all. In others, where there's questions about whether an adequate endometrial lining can be achieved, it may be beneficial. But at this point, I probably don't do too much of that.
Yeah, I do think they can be very beneficial for many patients who may have limited embryos, or we're not sure how their lining will look if they have a history of thin lining, or sometimes we might want to do a kind of a trial run to see what things are in. There's two different things. You could do a mock cycle with the medications. Some people do a mock transfer to actually basically pretend to put the embryo in to make sure it's easy to get into the uterus. So there's a lot of different things you can do. And I just think, again, it depends on the patient. We always make an individual decision for you. As far as the ERA test, we both have used this for patients. Again, we don't have the data that every patient needs to do that, but for some patients, I have used that if they've had some negative pregnancy tests after multiple implantations, or if they just feel like, hey, I've done all this and I only have 1 or 2 embryos and I want to do everything I can. Again, we don't know if it's necessary, but sometimes you don't want to find out on the other end. So we find out what's right for you. I don't think it's a good question. It's going to be covered by insurance. I don't think so at this point, because we don't have adequate data to show that it's definitely beneficial. But again, I've had many patients who I think it did help them. Again, we don't know. We don't know if we didn't do, but no one wants to be. This is a hard thing where your embryos are limited, and this is hard, and it's emotional and expensive. And we don't want to, we want to give you we want you to get pregnant right away, right? So, we'll do everything we can for you.
I don't think I can add anything to that.
Okay.
Previous patients can come see us.
Yes, yeah.
Absolutely. Very happy to see you. It's very easy. If you go on our website, there are several different ways you can contact us, phone or through the internet.
Yeah. Any one of our receptionists, they're amazing. Linda, Tori, Gina, Julia, they can all help you and help you schedule. So yeah, we're happy to see you. So just either call or send a portal, whatever you want to do.
If you have quality embryos, both male and female, does the patient have a choice? I have 6 boys, secondary infertility. Absolutely. So selection of the embryos can be done based on your criteria. If you have more than one healthy embryo, then you can select which one you prefer to use.
Yeah, I agree. So we allow that. So in some situations, we may tell you, hey, we think this one might be a little better than the other one. But if that is your, those are your embryos, and that's what you want, we would honor those wishes, and you could choose. Okay. Oh, thank you, Amanda. That's so sweet.
We're reading through some very nice comments.
Really nice messages.
Thank you. So a question about period cycles that are shorter and lighter, but consistent each month. Does this mean that there's low egg quality? So this can be a complicated question, but not too complicated. So to begin with, a average cycle length is about 28 days, right? But some women have shorter cycles, some women have longer cycles, and that would be completely normal. When cycles get much shorter, so like 22, 21 days, 23 days even sometimes, we start getting worried, could there be something wrong with the second half of the cycle, and that's called luteal phase deficiency. So this usually does not imply that there's anything wrong with egg quality, but it may talk about the quality of what's called the corpus luteum, which is what happens to the follicle after it releases the egg. Does it make adequate progesterone to support the second half of the cycle? So making this diagnosis is not easy because the tools that we have to make the diagnosis are not very consistent or easy to use. So generally, to make the diagnosis, we look at your history more than anything and see if we can establish the length of your luteal phase, and that can be done by following your cycle in the office or just doing a diary and so forth at home. And then that's something that we can easily fix or overcome by just getting adequate progesterone support in the second half, and that's easy to use, cheap, safe. So oftentimes, if there's any doubt, it's better to err on the side of just giving the progesterone in these situations rather than trying very hard to make the diagnosis.
I agree. Does your office collaborate with physicians for interpreting fertility blood tests for patients whose insurance do not cover fertility specialists? I mean, certainly we're always willing to give you a second opinion if you bring us records, and if you have, blood tests, we could potentially give you a second opinion and review all those for you.
Question about fertility medications and side effects, and particularly risks of multiple babies, multiple gestation. So depends on what type of treatment's being used. So for example, our less aggressive treatments that we think about, like using fertility medications to help with ovulation, medications called Clomid or Letrozole, these may cause the release of more than one egg and therefore result in a higher risk of having more than one baby. In general, if these medications are done in our office, we will monitor the cycle and see how many eggs are going to be released, and therefore we can control the risk of having more than one baby. Overall, we quote that the risk of multiple gestations, twins, with these medications in these types of cycles is about 10%, with 1% being triplets. So that would be a standard statistic. We try to keep the numbers down by the monitoring and not proceeding with cycles that get too many eggs. And also we try to use lower doses medications to not result in too many follicles. When we do IVF, we have much more control over that risk. So if we only put in one embryo, the risk of multiple gestations can be very low. It's not zero, because even if we put in just one embryo, that one embryo can still split into identical twins. So the risk becomes low, but not zero. And most of the times we strive to keep the risk of multiple gestation down, because we know that the healthiest pregnancy is a singleton pregnancy, and the risk of complications goes up significantly if you have more than one baby. So our goal is to always give you the best chance of having a healthy pregnancy and a healthy baby, not just to get you pregnant.
I agree. Someone asked what the age limit is for donated embryos. So we will say, so for donated, if you're using donor embryo or egg, our top limit is 55. But I will say we do want you to have medical clearance from your primary care doctor, as well as likely a cardiologist. So an EKG stress test, making sure you're super healthy, because the risks in pregnancy are really high, really above 40 and 45, and then more so above 50. So we want to make sure that you're safe too, as well as we want you to have a maternal fetal medicine consult. So we do have some medical things we want you to go through. So that's just not a blanket number, but that is what we will go up to for donated eggs or embryos. We're just looking through, looking at all this.
There's a question about DNA fragmentation and how it affects embryo development after implantation. So just to back up a little bit, when we talk about DNA fragmentation, that refers to quality of the sperm. We as the field know that DNA fragmentation is a significant issue for sperm quality, and we are continuing to explore and do more research on this, but it appears to be mostly now associated with risk of recurrent pregnancy loss, repeat miscarriages. Mm-hmm. So in couples who have recurrent miscarriages, this is one of the things that we're looking at in particular, along with all the other tests for why these miscarriages may be occurring. So yes, the answer is if there is severe DNA fragmentation in sperm, it may impact sperm quality, which can in turn impact embryo quality and success of those embryos in the long run.
Yep. How do we transfer embryos to your office? We just basically, you talk with our embryology team. They're amazing. Mark, Stephanie, and Carly. There's paperwork to be done. There's probably paperwork to be done at the other practice as well. So you definitely want to coordinate with both embryology labs and get their protocols. And there are going to be forms to sign and notarize. So it is some work, but you can do it. Lots of people do it. And you just contact our office and we'll get you in touch with the right people. Okay.
I don't actually know the numbers.
So for genetic testing on embryos, it depends. Again, most insurances do not cover that. There are some that are covering the biopsies, some that cover, I think Progeny does cover the testing now. So there's different insurances that, cover, not cover, but most do not. It can range from probably about $2,000 to $4,000. And I think somebody did answer your question too. It's really nice. You guys, you're all amazing. Sometimes they'll have a number up to a certain number of embryos, and then after that, it might be per embryo as well. So you have, one thing is you just have to decide what's right for you. Is this important to me? Because you have to look at, is this something I want to do? Do I want to test the embryos? Remember, the PGT is not perfect. It's about 90 to 99% accurate. So there is a 1 to 2% error rate. You can get a normal embryo, an abnormal embryo, a mosaic. What does that mean? That some cells are healthy and some cells are not. And some studies show that some of these maybe low mosaics potentially be healthy babies, but it's also you're not sure. So you're not sure which way it's going to go. And then sometimes we don't get a result where the DNA doesn't amplify. So sometimes the lab can rebiopsy if it's a good enough quality, but sometimes they might say, hey, I don't want to do that. And that's where you have to make an informed decision. So you talk with your doctor, you can talk with a genetic counselor. So some people tell me, hey, this is something it's really important to me. I really want to do that. And other people say, you know what, I want to give each embryo a chance. I might get this report and think, I don't believe this, or I still want to transfer the abnormal embryos. And I think if that's the case, maybe you don't want to do it at all, because you might not change your mind about what you do. But there are some studies that show it could potentially shorten time to pregnancy and reduce the risk for miscarriage. We can't say eliminate, unfortunately, because sadly there are some people who have losses even with seemingly normal embryos, and that can be so, first of all, any miscarriage is devastating, and we're always so sad for our patients. But there might be something else with the embryo, there might be another reason. Of course, we always do a full pregnancy loss workup in that situation. So again, it doesn't eliminate that, but it can reduce it. So if you're looking at, maybe I'm not spending money on those transfers or the time that I'm saving, then that cost savings can really be there. We think it's probably kind of I push it a little more for the older patients because they have, much more higher chance of abnormals, but really I offer it to everyone because it might be right for anyone at any age in their situation. Yeah.
Yeah, the PGTT, preimplantation genetic testing, genetic testing of the embryos, is definitely a powerful tool in our toolbox, and it's a complicated one. So we definitely want to educate anyone prior to using this tool, just like anything else that we do.
Mm-hmm.
But it is a valuable tool that we use often.
Yeah. If the PGT comes out with no normal chromosome, would I still have the option to use one? We would need, a discussion with a genetic counselor and a special consent form. I think it's not something I would necessarily recommend, but yeah, we always have a discussion about that. Have you see a genetic counselor, and we do have special, consents for that, as it's still your life and your choice.
It also represents what the abnormality is.
True. Yeah.
The answer can vary. So if switching care to our practice for another practice, you need to transfer your embryos right away. No, so you can leave the embryos until you're ready to use them.
Yeah, I think, it's always, I tell my patients too, sometimes, I'm sure you do the same. Sometimes you just want a second or third, or another opinion, just another set of eyes. It doesn't mean you necessarily want to change practices. We're all here to take care of you. We're friends with a lot of people around the country. We talk to them all the time. We're all here to help you, and we just want you to find the right person, and we just want you pregnant, no matter where that is. So we're happy to give you a second opinion. If you want us to take care of you, we're honored to. It doesn't mean you have to move everything. You can just hold on and maybe have a conversation and see how you feel. So I am always very open with my patients about, if things aren't, if they're having, failed cycles and things aren't going well, like talking to other people. I'm always really open and available for questions and open to different things. And, sometimes you just want to, talk to someone else too. And that's okay, right? That's really okay.
Yeah, absolutely. There was a question about the current political changes.
Yes.
And the embryos, and are they safe in Delaware, and so forth. So obviously this is an evolving situation. We will see what the national picture looks like, but it certainly does look like in many states laws are going to be making it much more difficult for women to have control over their reproductive rights. And that can also impact what we do in IVF, because in some states these laws may treat embryos as having full rights, and that of course can complicate our practice or even prohibit our practice. The question specifically asks about Delaware, and so we know that the current situation in Delaware is a very safe one for our practice. Delaware has many laws on the books that safeguard women's reproductive rights, and in fact just more were passed through the legislature today and are going to the governor to be signed, that offer a lot more protections for women in Delaware, and even women coming in from outside the state in terms of their rights here and their protections. So for the foreseeable future in the state of Delaware, we are very reassured that our practice and the embryos and women's reproductive rights will be respected and honored, and I don't see any of these things changing anywhere within the near future. Of course, we have no way to predict what the political climate will be in the farther future, but for now I feel very comfortable.
Yeah, I agree. We're hoping for all women to have the same reproductive rights. We do feel a little fortunate in Delaware, but I think for now you can all feel comfortable in Delaware. But again, we all need to use our voices and talk to our representatives and just make sure people know how we feel about this. Okay. How often does DIRM perform IVF cycles? So we do IVF cycles all the time. We do, for our quality control and for our lab, we do batch the cycles. So we typically do a cycle a month. July is a 2-cycle month for fun. But we also are able to work outside of that too. So we see many patients for fertility preservation who might be undergoing like emergent chemotherapies, things like that. And so we can certainly we can work outside of those as well. Okay. But we do many cycles throughout the year. Again, typically batch them monthly, but again, can work outside of that as well. As far as the out-of-pocket costs, you can call our office or send a portal, and there are many patient advocates who can help you with, our billing team and our front desk who can give you that information. Okay. Okay. It's been really nice to talk to all of you.
Yeah, these have been great
These
questions.
have been amazing questions. You're all so super smart. This is a good, we didn't talk about this. I know other RE offices are 100% ICSI. Okay, so we are not, I think historically we do a lot of ICSI, right? Because there's a lot of reasons for that with, low sperm counts or prior failed cycles. If you're using frozen eggs, you have to do ICSI. If you're doing genetic testing for a specific genetic disorder, you have to do ICSI. We do have the capability to do what's called conventional. So there's two types of fertilizations, conventional and ICSI. What are they, right? So conventional is when you take the sperm, you wash it, and you give each egg a group of sperm. ICSI is when you wash the sperm and then you pick the best looking one. Remember, you can't genetically test it though. You can pick the one that looks the best and that's swimming forward. And so we know for sure you need to do that when there's a severe malfactor, really low morphology, low counts, low motility, when you have sperm retrieved from the testicle. Again, we're using frozen eggs, a prior failed fertilization, again, PGTN, what's that? For a monosomic disorder, you were looking for a specific disorder. Let's say both parents carry cystic fibrosis or some other condition. You have to use that so there's no extra DNA. We have found there's some studies that show maybe some people don't need ICSI, right? And so we do have the capability for that. Like maybe someone has blocked tubes and the husband's sperm is perfectly fine. So then why would we do another procedure just to do a procedure on the egg, on the egg? And so there are, in some ways, sometimes a little hands-off can be better. Again, it's an individual decision based on the medical facts of the situation. So don't compare yourself to someone else, until so we're always looking at those parameters because we don't want to fail fertilization. That is horrible. But, I think the data are, correct me, I think you need to do 22 ICSI cycles to prevent one failed fertilization. I think it's around there. I have had some patients where I saw them and it ended up maybe that the conventional was better for them in their situation. But we do both at DIRM, probably higher percentage of ICSI, but we do both depending on the situation.
And there are other tools we have for selecting sperm as well that's when needed. So there are things called PIXI and mRNA-based binding assays. So there are many tools in our box, and the point is that we always try to find the best tool for the individual patient that we're trying to help in that individual case.
If the man has a low sperm count, how is there medication for him to take to help? So that depends on the diagnosis, right? So we always have patients repeat a semen analysis, right? So the sperm cycle is about every 72 days. It's called spermatogenesis, that life cycle of the sperm. And it can be different. So perhaps the sperm ejaculated today was affected by something that happened about 3 months ago. And, if someone is sick or, had a fever or something. So we say, let's repeat the semen analysis first. But we also like to refer you to one of our colleagues in urology. We have many people we work with who are great in Delaware. And we want your partner to be evaluated, for, a testicular exam, male hormones, things like that. So sometimes there's let's say the testosterone is low, people use medications like Clomid and Letrozole to help that. But we don't just want to give that without knowing the reason why, right? You always want to know the diagnosis. So it's important for him to get evaluated for his medical, his medical history and a physical exam, and make sure we're doing the right treatment. So there's many different treatments for male fertility, but there are some ways we can treat that. We'd like you to see a urologist. If you want to add any more to that at all.
No, I think that's pretty complete. Yeah, and then so how long is the IVF process? Well, if we're just doing an IVF cycle and we're going straight through with a fresh transfer, it's actually not that long. So from the start of taking medications to putting the embryo into the uterus is only about 3 weeks. So it's actually quite brief. Now, It may be longer than that. Why? Well, because first of all, we have to get to the IVF, right? So we may need to do some testing. So if you come to our office, we're not just going to boom do the IVF process next week. So we need to make sure we have all the right information, all the right testing. So that may take a month to collect all the data and make sure everything's okay, and then plan for the treatment. So the planning stages take some time. And then if you're not going through with a fresh transfer, because you're going to do chromosomal testing of the embryos or refreezing the embryos for other reasons, then there's going to be time to recover from the IVF cycle and get the embryos ready. And so there may be another month before you actually proceed with the frozen embryo transfer. But the simple question with the simple answer is about 3 weeks from starting medications to putting an embryo in, if we're going right through to it.
Yeah, I agree. Yeah. If you have female and male factors, would IUI even be considered, or mainly only IVF? Was told IVF, but then conceived natural, but now 7 years. Well, first of all, congratulations on conceiving without any help. I always find that really fun, and I always get really excited for you, don't you? Yeah.
Absolutely.
It always is so great because we know this is so stressful, and we always love when you have that good surprise. So remember that even if you have difficulty getting pregnant, it doesn't mean you can't, right? But we also don't want you, the reason we recommend treatments is we don't want you wasting any more time, and we know there's medical reason to be more proactive about it. But you just never know when that healthy egg and sperm will come together. But if it has been a long time, I will say IVF would be probably the best treatment, given, I'm not sure about your age or whatever. It's probably going to help you the best. But given the situation, maybe depending on your age, if your tubes are both open and how, is the sperm abnormality mild or not, you might be able to try IUI first too. So again, it's an individual decision, but I would have to know more information too. And we'd be happy to talk to you about that.
Absolutely, and it's a very important question to begin with, because infertility, like you just heard Dr. Bachman say, is not a diagnosis that you have no chance of getting pregnant. We always talk about the chance of pregnancy. So even someone who has not gotten pregnant in 7 years could be pregnant tomorrow. That's very possible, but the odds are low. And so what we aim to do is try to increase your odds as much as possible. Nothing we do is 100%. We just want to give you the best chances possible, right? So the second part of the question is male and female factors. Well, what are they? If a woman just simply has an ovulatory dysfunction, not releasing eggs regularly, and there's a mild sperm abnormality, then absolutely, maybe we can use medications like letrozole to help her ovulate, and do an IUI to help the sperm reach the egg, and maybe that's all we need. So it really varies, and just like Dr. Bachman was saying, it really is something that we would need to discuss and talk about the pluses and minuses of all the options.
Totally agree. Well, I think we'll wrap things up tonight. We would love to see you, so please send a portal message, go to our website, give the office a call. We'd be really happy to take care of you. We do all fertility, treatment, which we help both, male and female couples, same-sex couples, single patients. We do, all aspects of fertility treatment. We always want to diagnose you with your medical problem. We offer, medications, IUIs, IVF, donor egg, donor embryo, gestational carrier. We also work with both known and, we call that directed donor now, and then the, non-identified donor as well. So we have donor agencies we work with, as well as if you have someone that that, there's certain processes we have to go through, but we can work with that as well. We do treat PCOS, endometriosis, fibroids, things like that. We do fertility preservation for medical procedures, such as cancers and other medical problems that are using medications. We do help transgender patients with undergoing treatments before they undergo hormonal treatments, saving either eggs or sperm. So we offer a wide range of help. We help, patients who, want to freeze their eggs due to their age, and if they haven't, found a partner yet. So we're here for you in all different aspects of the fertility. I hope I didn't forget anything. I don't think so, right? Yeah.
That was pretty comprehensive.
Yeah, pretty comprehensive. We really thank you all for joining us, and we look forward to seeing you in the future. Okay?
Absolutely. Thank you so much for everyone who joined, and I'm really excited to be back in Delaware practicing
Yes,
with
we're
Dr.
so
Bachman
happy to be
and
together
Dr.
again.
Russell.
Yes.
And
Yeah.
if you have questions, please come see us.
So yeah, come see us and Dr. Russell and our whole team at DIRM. We're really happy to meet you. Okay, or see you again too. So some of our friendly faces around here. All right. Have a good night, guys.
Good night.
Bye.